So my name is Matt Odenwald, and as Dr. Chang said, I'm a current GI fellow here at the University of Chicago. I grew up in the Midwest in the St. Louis area, where I also went to college at WashU. And after that, I moved to the University of Chicago in 2009. And as Dr. Rubin says, the University of Chicago certainly has a way of holding on to us. And I've been here ever since, as you can see, for the remainder of my training. Throughout my clinical training, I've developed a particular interest in liver disease, and I'm really happy to be able to share an overview of my research with you tonight. Next slide, please. So many of the talks so far have dealt with luminal disease. So I'll give a brief overview of the liver. The liver is a solid organ about the size of a football that sits in the right upper part of the abdomen. And it interacts directly with the gut, both through the bile ducts and blood vessels. And one of its main functions is to filter all of the blood that returns from the gut. The liver also regulates blood clotting and even serves as a key immune organ fighting against infection. And with so many distinct functions, it's no wonder that patients with advanced liver disease are often considered some of the most critically ill patients that we see in the hospital. Next slide, please. Unfortunately, the incidence of liver disease and liver cancer has been rising for many years and is expected to continue to do so, and may even take on a rising rate with the COVID-19 pandemic, weight gain, and increasing alcohol use. While there have been many advances in screening for liver disease and treatment of certain viral liver diseases and even liver cancer, treatment of liver cirrhosis and its complication remains largely supportive without any targeted therapy. Next slide, please. So I'm very lucky to be surrounded by many experts who aim to harness the power of the gut microbiome to prevent and treat human disease. As you may have, we've heard a little bit about tonight, the microbiome refers to the trillions of bacteria, both healthy and harmful, that live in the gut. And each person has a unique microbiome that depends on both host and environmental factors. These bacteria break down the molecules that we eat and that our liver secretes into the bile. And these products are called metabolites, which can modulate human physiology, gut function, and even the immune system throughout the body. Next slide, please. As I mentioned, there are direct connections from the liver to the gut, both through the blood vessels, and all the blood from the gut drains directly into the liver, where it's filtered, and the bacterial metabolites, components, and occasionally even entire bacteria interact with the liver before going on to interact with the rest of the body. The liver communicates back to the gut through bile secretion, which can then in turn alter the makeup and function of the microbiome. And so with this two-way communication, we think that the liver can affect the gut microbiome, and the microbiome can in turn impact liver function, disease progression, and the development of disease complications. Next slide. We are therefore asking the question, does the gut microbiome and its metabolites predict important clinical outcomes in liver disease? These include the progression of liver disease to cirrhosis, shown here on the left, and the development of many of the complications of end-stage liver disease, including infections, bleeding, kidney failure, and even death and the need for a liver transplant. Next slide, please. To study this, we're starting with extremely generous patients who allow us to analyze both their stool and the blood here in the Duchossois Family Institute, or the Microbiome Institute here at the University of Chicago. And here, the genetic makeup of the microbiome is sequenced, and the metabolite profile of each patient is characterized very carefully by Dr. Sidebottom's group. We then access extensive amounts of data in the medical records, and we correlate the composition and function of the gut microbiome and the metabolome with important outcomes for our patients. And our ultimate goal is to design rational treatments that can target the gut microbiome and improve the care of patients with liver disease. Next slide, please. So I've been doing this for about 6 months, and this is a little bit of an older slide, but in just 6 months, we actually now have 260 of our 500 patients enrolled. So we're over halfway done enrolling patients. We have many generous patients, and we're starting to begin data analysis with plans to present and publish this work in the future. And as I said, the ultimate goal is to perform interventional studies that are designed with these results in mind. So with that, I'd like to say thank you for your attendance tonight, and I look forward to your questions, and really I do appreciate your support of our GI section and the GI Fellowship.
My last few questions are for you, Matt.
All right.
You know, I personally think that there is a intimate connection between the microbiome and liver, liver function as well as disease. So, it's enormously difficult to do what you're doing. That is, studying human subjects. And you basically end up with a lot of associations. So, how would you go about actually understanding what mediators, molecules, microbes are affecting liver function and vice versa? How would you look at, let's say, bile or other products made by the liver that might impact the membership as well as function of the microbiome?
Yeah, that's a really excellent question. And I think one that's kind of plagued the field for a long time is as a field, we get a lot of very interesting associations that sometimes mean something and sometimes don't. But I think that the main part of this work is that it is a bit hypothesis generating. So it really, we can see these associations, and of course, they don't mean causation. Just like the work that Dr. Skowron was talking about, we're looking backwards, not necessarily looking forward. So with these generating hypotheses, we can see different associations between treatments of liver disease and both favorable and pathogenic bacteria within the guts of our patients. And they're leading to some mouse studies and in vitro studies where we can more closely study the precise interactions between different bacterial groups. For instance, one finding that we've had so far, really with preliminary data, is that a medicine called lactulose, which we give to lots and lots of patients with liver disease, we think of it as gastroenterologists just as a laxative, seems to have a really remarkable prebiotic effect and really expands very healthy bacteria, which was a surprising thing to me in patients that are hospitalized with liver disease. And it seems to interact and suppress different pathogenic bacteria. So it's really generating different hypotheses at this point that will then go on to the lab and be able to be tested.
Great.
So bench to bedside, and then hopefully back to our bedside to bench, and hopefully back to bedside is the goal.
Right. So, one of the unique features of your research is that you're going to actually sample the biliary tract and look at microbes or microbial products that are going directly up to the liver. But that points out that most of these microbes are probably coming from the small bowel. Nobody pays attention, or very few people pay attention to the microbiome in the small bowel. I wonder what your thoughts on that are.
That's a very good question. And right now we are studying the stool microbiome, which is a limitation of the study. And the small bowel certainly, I'm sure, plays a very important role in this as well. I think one of the really big points that I've seen so far in my preliminary data that points to that is an antibiotic that we give to a lot of these patients is called rifaximin or Xifaxan. And based on stool samples, it seems to have almost no effect on the stool composition or microbial composition in the stool, but it has remarkable clinical effects. And so that would argue that it's working much, much higher up, at least for the complication that we're treating, hepatic encephalopathy. And I know that other people, like the surgeons, often use rifaximin prior to small bowel or colorectal surgery as well to clean out the bowel. But it really seems to have its effects higher up. So that is a very good point. It's something we haven't looked into yet. There is an ongoing study for patients who've gone on to liver transplant, where they are doing biliary aspirates or duodenal aspirates at the time of transplant and correlating that to outcomes, including rejection and development to infections. And many of those patients are included in my study too, but they're not. That's not the primary sample that we're able to obtain.